hoping you can all hear me. My name is Tia Moscarello, and I am the co-chair of the Student New Member SIG, and this webinar is Psychiatric SIG, where we are going to have several current student experiences. Beginning on this webinar is not for CEUs. It is intended for students as well as new genetic counselors who would like to create a kind of non-traditional rotation. We'll get started, I guess, with our first speaker. I'm just going to double check that I have no chat messages. No. Okay, for all of you attendees, if you have any questions throughout the webinar for a particular speaker, please enter it in the question box, and I will be moderating those throughout the presentations, and we'll come back to them at the Q&A. Okay, so I will start with our first speaker. Our first speaker is Karl Castrataro, and he is studying at McGill University. So first of all, Connor, I'll have you introduce yourself, and then we'll go ahead and talk about the rotation that you had, and then we'll start the conversation from there.
All right, sounds good. Thank you, Tia. So my name is Connor. I'm a second-year student at McGill, as Tia said, and I'll actually just start with a quick disclaimer that I do have a patient in about 1 hour. So if this does happen to run longer than expected, I may have to head out a bit sooner, but I'm good for the hour. So my rotation was done at Weill Cornell Center for Neurogenetics in New York City. And the reason that I picked this rotation was that McGill's program is very clinically focused, which I love. But knowing that genetic counselors can work in other settings, I wanted to experience that for myself, as well as get a feel for clinical practice in the US and Canada. Dr. Elizabeth Ross, who's an MD PhD, Shanila Lakhani, who is the Director of Genetic Counseling at this, as well as a team of bioinformaticians, basic scientists, fellows. So to see patient building, and we go to 3 different to do the actual genetic counseling. Sorry, enough. All right, so if I have to give, I guess, like an elevator pitch for Cornell Center for Neurogenetics, I would say first and foremost, it's a research center. The genetic counselors just act as one of the many clinical liaisons. So in our role, we can order clinical testing as a first-line investigation for the patients that we see. But there's also this component of research that we're able to integrate in, which was really fun. So naturally, the patients that I saw were all referred from neurology, and we worked very closely with the neurologists. So as for the research component of this rotation, when I arrived, there were 2 whole genome studies going on. The first one was called Adulthood and Aging, and the second one was a pharmacogenomics study. So the genomic studies were done just on DNA from the blood, and these studies could also be supplemented with functional assays using fibroblasts from skin biopsies if patients consented to that. And when I arrived at Cornell, I was offered sort of whichever, I was asked which project it was that I wanted to work on, and I didn't really know at the time. It was really my first exposure to non-clinical genetic counseling. So I just was kind of frazzled and took on whatever, and I ended up being much more involved in the Adulthood and Aging study. And so what this was is, despite the name, it's really basically more of a, at least for clinically speaking, it's sort of like a last-ditch effort to find a genetic diagnosis through research. So there were no really strict criteria as to when it was offered. I think ideally it was to benefit people who have already had very exhaustive genetic testing and clinical workup, so as to see if there's maybe something we can find that would not have been otherwise detectable on a clinical exome. So the workflow for this study, in terms of going from the research to the clinic, was when the blood was drawn in clinic after consenting by the genetic counselors, it was the sequencing itself was initial criteria. We would usually be working with a list of it, like, low hundreds in terms of variants that we ourselves had to really sift through and look into. Sort of integrate the clinical information from these patients to see if we could find any candidate variants. So the first level of this would be the gene curation, just looking through all the different variants and which genes they're contained in, and sort of trying to assess whether these genes could possibly be related to some sort of neurological disease. And then once we filtered these out from the suspect gene group that we have, that's when you do the actual variant interpretation within each gene to try and see, is this variant really disrupting the gene, and could this variant cause some sort of neurologic disease? And then just so that these candidate variants were not just seen by one set of eyes, they were then presented at what was called variant rounds, which I think were occurring monthly. And this was in front of the whole Center for Neurogenetics, the whole multidisciplinary team, so that we could discuss them all in a group. So basically, we would provide a chart review of the patient, and oftentimes members of the team have already seen these patients in clinic already. These are patients that are known to the team. And then we talk about what the candidate variants that we thought were, and just sort of get an idea of what people think. So as a trainee, I would work on one of the genomes in parallel with the working genetic counselor to see if we would arrive at the same results that she presented at variant rounds. And that was sort of how my training for this rotation took place. So what I really liked about working at this center was it had a really good sort of holistic approach to genetic care. We're really working with the patients from clinic and then into research and then back into clinic. So it feels good to be able to keep pushing and provide extra options after the clinical options don't really yield the result that we want. And it's also a good opportunity to integrate research into clinical care. What I liked a bit less was that it could take up to a year for results, but this is to be expected because it was a pretty small team. We were also outsourcing our genome somewhere else, which was not always super. Because of this, I never really got. It was all super impressive to me nonetheless. So I think from this rotation, really what I'll take with me is more concretely, I think I learned really valuable skills in gene curation, and that is to be able to be the ones to continue offering these extra steps and to take the clinical investigation really as far as we wanted to. And I recognize that not every center, of course, is in the financial position to do so and to have these systems in place and these programs, but it at least opened my eyes to sort of what is possible with the right support and what our value really is and all that. So with that is all I have to say for now on that rotation.
Thank you, Connor. That sounds like a really, really interesting multidisciplinary rotation where you're kind of going bedside to bench and potentially bedside again. And the partnership between the institutions as well sounds like it was something of a challenge to navigate, but you kind of got that experience of what it's like in a real workplace.
Yes.
Great. Since I will add any questions that came in to the Q&A at the end. And of course, I'll be sensitive to the time that since you're going to be, you have to leave right on the hour, we'll probably ask your questions first, Connor.
Okay, thank you.
Thank you. So I'm gonna go ahead and mute you and then, oh yeah, you already did that. And then welcome Jimena Hernandez, who is at the University of Minnesota, and she will be presenting on her time at the Mayo Clinic lab. Jimena, go ahead whenever you would like.
Hi, so my name is Jimena, and I am a second year genetic counseling student at the University of Minnesota, like Tia said. I'm originally from Mexico, but I did my undergrad in Dalhousie University, that's in Halifax in Canada, and now I'm here in Minnesota. So actually I'm doing all of my rotations, both clinical and non-clinical, at the Mayo Clinic. So as rotation and it was really good. We had 5 weeks, and the first some of the individuals that prenatal, so I got to do a lot of things in regards to Beckwith-Wiedemann syndrome and Russell-Silver syndrome testing. So I learned a lot about what the people at Mayo, kind of the reflex testing and all about that. And I also would there's multiple kind of like in different what they call pods. So they're in different areas of the lab. So it could be molecular, it could be cytogenetics, it could be prenatal. So I worked with that specific pause. What I would do is I would connect with them via Skype, and we'd kind of go off the list of patients that were waiting for test results, or that we had to say, yes, go ahead with the test, or no, we need more information. So I would kind of run through that list every morning with them, and they would ask me for my feedback saying, what do you think this test is appropriate for the indication? Do we need more information from the patient? So we would go and call the provider and ask, hey, you ordered this test, but actually we think this test might be more appropriate. So I kind of did all of that, and it was a good way to see what kind of a genetic counselor that works in a lab does on a day-to-day basis. So it was really good because I was able to sit on those calls. I was able to provide my feedback of what I would do, and then they would tell me yes, or they would try to explain kind of what it looks like on the lab side, because I think it's very different from the clinical side. And it was interesting to see how those things play with each other. And then after that, on the last 2 weeks, I did a cytogenetic rotation. So what I did is I went with the cytogenetic lab GCs, and I kind of learned about their microarrays, their cutoffs, and I also did array interpretation. So as part of the University of Minnesota program, we do have a cytogenetic class. So I was already kind of knowledgeable about how to do array interpretation, but I think doing it with the Mayo people, it was easier for me to see kind of like a real case scenario, and they were able to walk me through how kind of they work through a case. So what the lab GCs there is, they get a result and then they interpret it, they write the report, and then they send it to the consultants, the geneticist consultants, and then they approve it and send it out. So she gave me a case that's a real case at Mayo, and then she told me to go and interpret it, and then I came back and compared it to what actually happened in the situation. And I think it was just such a good experience, and kind of seeing what areas of lab I thought it was like, oh, very interpretation only or array interpretation only, but it's interesting to see all of the different areas are involved in. I also got to do, so apart from doing all TRs, so the genetic testing registry, on ENSLO their tests from different laboratories and by how much they can at various tests. So I put up together a document if anyone ever in the future wants to upload a test, a Mayo test on there, what they need to do in order for us to be more visible. And it was really interesting because I was able to compare and contrast like top tier labs, what they have on the genetic test registry, and then also how those tests compare in the background. So going into their lab websites and seeing what is their methodology look like? Do they do any confirmatory testing? Do they do prenatal samples, parental samples for free, etc.? So I think it was just a really good experience. And then I got to present to the lab GCs what I found, which was also a really good experience. At the last day of my rotation, I also got to do some mock calls. So I called people pretending that I was like a lab GC and saying, what would you do in this situation? So for example, we got a newborn sample to rule out Klinefelter syndrome for a baby girl. So that's very unusual, but I kind of walked through what would you do as a lab GC on the other end? Who would you call? What would you ask? What would you suggest? So I think it was really interesting to see that from the other side, because before that I was just in a clinical rotation, but seeing on the other side, we might send something and what the lab GCs do once they get those referrals for testing. So overall, I think it was just a really good experience. I also got to meet like a lot of the other people that are not GCs that work in there. So like lab technicians or the consultants or different individuals, GCAs as well. And it was really good for me to see kind of how they work together, which was not something I was used to in the clinical setting, but it was really nice to see how everyone trusts lab GCs a lot, and how the fellows relied on a lot on what the lab GCs do. And some of the assignments that I did were also some assignments that the fellows did. So it was really interesting to see that and meeting all the different people and kind of see them working together. And the lab environment was very different than the clinical environment, which was not something I was expecting. But yeah, overall, I think it was a really good experience.
Jimena, that sounds so interesting. The mock calls, especially kind of the critical thinking, as well as how you would explain that to either a patient or provider. That's great.
It was really good.
Thank you. And 5 weeks, that must have been pretty intense. That's not a very long time to get settled.
No, it wasn't, but it's nice that I do my rotations at Mayo already, so I kind of knew the people already, if that makes sense. And then we would get testing from like JCs that I worked at the clinic, so it was kind of nice to see that. And like, I don't know, it's kind of nice that I still get to like my
And I got into this rotation in a little bit of a funny way due to some switching around of positions. I was needing a new rotation for the summer, and after that week spent there, I was like, wow, this is really interesting and something I never considered when I went into genetic counseling. So I was able to reach out to the supervisors there, as well as our clinical director at the university, and I was able to get in the summer. So I was really grateful to be able to have that opportunity and be there. And I guess walking in, I had no idea what to expect, because all I had done there was newborn screening, and I didn't know if I'd be doing more of that or helping with some of their more long-term project goals. So when I walked in, I just kind of was going with the flow, ready to be flexible to see what they would present. What I really liked about the rotation was that was kind of the mentality that we took throughout the entire rotation. And so throughout the 5 weeks, I had kind of a smattering of, I would almost call them informal interviews / just discussions with people from different, like little, I have the word pods in my head after Jimena said that word, but just kind of different sections of the Department of Health, where it was either part of the audiologists that do some of that hearing screen follow-up, or some of the genetic counselors involved in the cardiac follow-up, or the blood spot testing. So I was able to meet with probably a dozen people at the Department of Health and just learn from their experiences, their day-to-day life, and just show to me the skills that they have learned. Some of them being genetic counselors, different healthcare, not necessarily public health. So that was really fascinating to kind of have one of those at their job, and then I would be able to talk to them about some of the genetic counseling things I was learning and learning environment there. And then other than doing those, so the Department of Health right now is, I think they're on their 5th year. They're starting up a project to do the learn. 10 years ago, there was some research, as we know, in the world of genetics. They're trying to see if it would be more effective now, and they're actually having some really promising results about blood spot testing being an option for CMV. And the reason they're thinking about CMV testing is because that advocacy community is really invested in having this be screened. And it is one of those more controversial conditions, because if you're not familiar with congenital CMV, what happens is if a mother is affected with CMV, her primary infection while pregnant, the child has a chance to develop congenital CMV. And when you have congenital CMV, 80% of individuals have no symptoms. They're perfectly healthy. Whereas then you have a 20% that are symptomatic. And 10% of that 20% will be pretty severely symptomatic. And those are the ones we usually will end up catching. But what we end up missing later on is the 10% that seem asymptomatic, and then at some point within the first few years of life or months, they will develop hearing loss. So it's something that hearing loss, we know that in relation to development, if someone isn't able to hear and we're not screening them properly, that could really affect language and learning development long term, to a point where they may never catch up to where they could have been if it had been caught. So there's a huge advocacy community trying to push for this screening. So it was a really kind of cool place to be in that mindset of, okay, what does the advocacy community say, and how do I connect this to what the science can do with CMV testing, but then also putting on a health equity hat. And that's something that has always been passionate to me as an individual, but it's not something I've really been able to do in a clinical role, because I think you're in the constraints of your, healthcare network, and you're not necessarily able to, fix the insurance problems or do this. And sometimes you just have to try the best to fight for your patients, but it can be, frustrating with insurance and trying to figure out how to make things equitable for them, and it isn't helpful. But yet there's this huge advocacy community that's pushing for it. So it's a little contradictory. So what we worked on during my 5 weeks was to develop a parental survey to try to assess what the reaction is to getting these screen results and to be sending out. And, throughout the 5 weeks, of course, it's not necessarily enough time to fully complete any project like that, but I was able to get a good draft of a survey development, which is actually going to be one of the first years in my program's thesis project. So I'm kind of excited about the fact that something I was able to start is going to continue on in our program and hopefully lead some really interesting data, and to see what that would mean and to further kind of the newborn screening community. So that was my main focus during the 5 weeks, but given the flexibility of the rotation, about 3 weeks in, we sat in a meeting and they're like, we need new patient education guides for Bart's hemoglobin. hey, Bridget, why don't you do this? And so I was like, okay, I don't know about anything about hemoglobinopathies, but I'm ready to learn. So I actually was able to really get a lot of clinical knowledge under my belt during that rotation and really take an in-depth look at alpha thalassemia and Bart's hemoglobin and go into that and try to create patient-friendly materials. And one thing that is really, I think, was unique about that experience is these are materials that would go to people that screen positive on newborn screen. So you're reaching all different sorts of education levels. So you really have to kind of make it to be that most plain, patient-friendly language that you can. So it was a really good working of like tailwinds. And so it was a really new way to put that in a family lab. So that, I think, is just one of the big takeaways from the rotation for me. Was a lot of times we start to think like, oh, we can just counsel patients, we just do this clinic rotation now, but there's many ways that we can take our skills for health equity and psychosocial skills and family dynamics and use those to broaden care, as well as using our tailoring skills to create patient-friendly materials for all different kinds of individuals. I would say one of the biggest also perks of this rotation that's kind of like a funny one was that I got an hour lunch break every day. So that was beyond exciting because many people in clinic know that's like unheard of. So that was my favorite like fun thing that we did. But overall, it was just such an amazing experience to see that my skills were not limited to a box, that really the things I'm learning in grad school are skills that I can take anywhere that I want to go. Thank you.
Bridget, thank you so much. That was really interesting hearing the kind of, not just hearing about a non-genetic condition and how genetic counselors play a role in that, for example, CMV infection, and your role in that kind of public health initiative. Very, very interesting. Thank you for sharing. I will, again, keep a list of questions that are coming in. Karl is our next speaker. Karl Krahn. I'm sorry if I should have asked you how to pronounce your last name. I'm so sorry, Karl. He is at Sarah Lawrence College, and he is going to discuss his non-clinical rotation experience at the medical examiner's office in New York. I'm going to unmute you, Karl, and you can go ahead.
Perfect. Thanks, Tia. Yes, yeah, you said my name right, so thank you so much. My name is Karl Krahn, and I do have some slides. Are you able to share them?
Yes. Yes, absolutely. Let me make you the presenter. And then you should be able to share your screen. Perfect. I can see it.
Perfect. Thanks.
I assume others can.
Slides. Nope. Not sure about. Yeah. What? At the Office of Chief Medical Examiner, it's a very unique position. There's only one sort of like this in the whole country. And what they do is people who have passed away suddenly from a cardiac event, and there's kind of unknown reasons, then it goes to the Chief Medical Examiner office. And this is kind of like, I think Connor was saying with the neuro clinic, it's sort of the last line of defense or last line of research that we could look to see if we can find a cause for whatever the health condition is. In this case, the phenotype is confirmed. There was a sudden cardiac passing. So we kind of have a known portion of the phenotype, but we're trying to understand if there's maybe a genetic underlying cause to why someone passed away suddenly. So here was just a paper I had pulled that they published. You can see the PubMed ID there in case you're interested. And it's what they're talking about is just kind of what they do in their framework, and then there's kind of the stats that they had pulled, and I think it was from 2017. But just the quote that I found was they report an evaluation of cardiac channelopathy and cardiomyopathy genes in a large, demographically diverse, sudden unexplained death cohort that underwent thorough investigation in the United States' largest medical examiner's office. So a lot of unfortunate patients are coming through, and that's the kind of the interesting part of this whole job or this clinical position is that there is obviously there's nothing good about what is done here, but it's kind of the good is then helping the patient's family members, but not always patient's family members want to follow up with us, but for the most part they do, but it's kind of just trying to help then the family members to make sure that they are in the best position going forward, so they can kind of miss out on this event happening personally in their lives. House, which is different than some places. They only have one genetic counselor, they have a few lab techs, and they have approximately 4 or 5 PhD scientists. So they run the next-gen sequencing, and they get some mutations or some mutation hits, and then what happens is they pass it to the genetic counselor, then she does the research and kind of analyze all these variants and classify them. So that was part of my job, so to speak. I was given past cases because they're, as I show in the next slide. Oh, sorry, I'll just bump up to one more. Is that the major difference here is the patient volume. In 4 weeks, so again, I only had 4 weeks, but 2 patients were scheduled and 1 unfortunately canceled. So I only saw 2 patients in a total of 4 weeks, which I know is very low, but it's very hit or miss. The people that do come in and the family members that do come in and what autopsy reports and what genetic sequencing is happening in the current day or the current week. So this was even low for their standards, but you kind of just have to be flexible, and there's so much time for research, which I think is something that I enjoyed. I liked that there were many days, many hours to work extensively on one case or to start a new case. It's a definitely different kind of flow compared to a prenatal setting where you're seeing multiple patients a day. I was fortunate that my first patient was on the first day, so I was able to shadow my genetic counselor on the first day, but then when I had the last patient, which was supposed to be kind of right near my last week, they unfortunately canceled. But I still did lots of mock sessions, which I'll talk about later, which I think were very beneficial. So kind of these were the learning objectives that the genetic counselor had for me, which I think were very helpful in just going over what I learned or could find out during this rotation. So I learned a lot about the genetic causes of sudden death. I did a lot of research just in the genetics, which I'm still learning. I love, so it was a good kind of jumping off point for me. Obviously, there's many unique aspects of genetic testing in a post-mortem setting. Family members may come in to gather results and gather information, some may not. Again, you have the phenotype is confirmed, there was a passing, an unfortunate passing, but of course there's no family tree. You don't know of any or heart problems in the family members. That only can happen once the patient's family members come in and give that information. So you're working with some information, but you're missing out on a lot, and that's why you hope that family members come in so that you can kind of quantify that information for them and understand what else they have seen in their family and maybe what they haven't seen. Maybe people have passed away suddenly and they just didn't know kind of the reasons, or it was when they were in a car accident, but who knows the reason for that accident, unfortunately. So these then were the findings that the lab would give us. Again, everything was in-house. So it was just down the hallway, essentially. They were running these panel tests. So then a few mutations would get a hit, and then the classification, obviously that's where the work was involved in classifying, was it pathogenic, the US likely pathogenic, and those results then would be reported to the family members. And like in this case, we took the time to really dive into these cases. That's something lab mix of a genetic counseling position. I think that would be best for me, is letting me really sink my teeth into different concepts and be able to do some real applicable research for patients or family members. So again, we would do deep dive in the research, and then we would to come into a genetic counseling. Then, sorry about that. And then the psychosocial, like I had mentioned, you don't know what family members will come in. There'll be different stages of grief for everyone. It depends on the timeline. Things, sorry, my phone is being a bit fuzzy. I apologize if that's coming through. The timeline can be different. The grief can be different. It depends on how close the family members were to the decedent. Maybe it was a distant cousin, maybe it was the sister, the brother. It's all very different in just being aware and empathetic for all the situations possible. There's just many things that can arise from the psychosocial aspect. And then as I just think of non-clinical positions in general, I again really appreciated this opportunity because it really opened my eyes of what other genetic counselors could do. I know some of the other speakers have already talked about just realizing that your skill set or your toolbox is maybe bigger than you think. So there's just many opportunities that we may not think of beforehand about what we actually can do and what positions we're actually maybe best suited for, able to work in. So I really liked utilizing the prep time. I use a lot of mock sessions, so I would have these genetic variants and I would run through them. The GC had already come with a call. She already knew what I should get to, and each time I did get to her same conclusion, so that was exciting for me. And just working through those variant interpretations with the knowledge that I did have. Again, everything will be incredibly unique. It's very different than a prenatal or cancer setting. And I've been surprised how all blazing attributes, I guess I would say, to work together and kind of support everyone. So I really would like to find out going in, but I look forward to hopefully a position down the road. Okay to be over your head. I did not know what I was getting into. I applied for this summer position. I was thankful I got it, but I had to do a lot of kind of catch up in the beginning, a lot of research. But I think it was beneficial to kind of dive in and see where it went. My supervisor gave me a lot of lenience and a framework for me to just like figure out what I wanted to do with it. Amongst that, and I think having an open door, having her door open always for me was a great thing that helped me succeed a lot. So if you have any questions, obviously later, I'll be happy to answer them. Thank you.
Thank you so much, Karl. That's a really interesting rotation. I am very jealous of that, the fact that the medical examiner's office exists in New York. We need one similar to that in San Francisco or the Bay Area, because postmortem testing is very tricky if it's not done ASAP. So I loved hearing all about that. Our next and last speaker is Rebecca, and I don't want to mispronounce her last name. She just joined, so I will let her do it, and then I will learn for future, and I will know it. She's also at Sarah Lawrence and did her rotation at the ADAPT clinic, which I'm also really interested in learning about. Now, Rebecca, I will switch the presenter mode to you. And then you should see a button that will say show your screen. And then you can choose to show your entire desktop, or you can choose to show an application.
Okay, let's see if that works. Can you see my screen?
I can see some pictures. Instead of showing desktop, maybe show. Okay, let me try this again. Oh, now I have the like blue rainbow circle of death. Okay, wait. There you go, Bridget. Yeah. I think I passed it to you.
I'm not seeing anything come up.
Yes, I would like to make it.
Oh, okay, there we go. No, it's still not working. I don't know why. It might be my Mac that it doesn't like. That's okay. I can do without. I can do without the slides. That's okay.
That others can reference them later.
Okay, great. So my apologies for being late and missing everybody else's presentations. I'm sure they were fabulous. My name is Rebecca Haegedorn. I graduated from Sarah Lawrence in May, and I'm now a prenatal and cancer genetic counselor in Queens, New York. And over June 2018, I did my summer rotation at the ADAPT clinic in Vancouver, which is a psychiatric genetic counseling clinic and is sort of the first of its kind. I think there are now ones being opened that are maybe being modeled after that, but it was kind of the pioneer clinic.
So this was really part of the reason why I got into genetic counseling. I'm really interested in psychiatrics as well as genetics. So this was something that was on my radar even when I was applying to programs. So when I had the opportunity to apply for it, I really jumped at it and was lucky enough to be chosen for it. The main thing that I would say I took away from this rotation is that from the ADAPT Clinic Speak. If you have, you're probably STARS, which is just a very simple way of explaining multifactorial inheritance to people, because that's really what you're doing when you're explaining psychiatric illnesses to people who are affected by them or who have a family history. And so you're explaining how both genetic factors and environmental factors go into contributing to what we call the mental illness jar. And when that jar gets full of both of those factors, that's when somebody may experience an episode of mental illness. And so being able to kind of shift your education piece, it looks very different than it looks for other specialties. And I think there's a misconception very often among genetic counselors themselves. I remember a lot of my classmates asking me, you know, kind of what is the point, because if you can't do testing. And so it was a very interesting perspective to get on. Here's all of these beneficial things that we can give to patients, even though we can't necessarily offer them a test at the end of our session. So that was very interesting. With these jars, you can apply this model to any disease that follows multifactorial inheritance, which has proved very, very useful in my clinical practice. And I don't think I realized how much I took these skills away until I was actually working. You can apply this to heart disease, diabetes, anything that comes up in a family history that follows multifactorial inheritance. And very similarly with psychiatric illness, is those kinds of conditions are very often what patients are more worried about than their actual indication for referral. So for example, if you're seeing a prenatal woman because she's a carrier for cystic fibrosis, she's not necessarily scared of cystic fibrosis because she doesn't really know what that disease looks like, because she doesn't have a family history, because she's just a carrier. And that's such an abstract concept for people to hang on to. But if they have a family history of psychiatric illness, if they have a mother with depression, an uncle with schizophrenia, they know what that looks like and they know what that does to their family, and that's what they're scared about coming into your office. So yes, you still need to have, you know, all of your other skills that you learn about to counsel them from, you know, maybe that more educational standpoint on the genetics and everything, but being able to take that time to address their concerns about these other multifactorial conditions like psychiatric conditions is just huge in building rapport, and I really think it helps patients get more out of it. So I think that would be kind of my main takeaway from this rotation. And it really, where this was structured in terms of my learning was I came out of my second year only having really observed genetic counseling sessions, and then I went right into this rotation. So it really helped to isolate my psychosocial skills right off the bat. And I think that that's something that carried through the rest of my education. I always kind of approached things with this perspective, which is maybe a little bit different than people who start in a cancer or a prenatal area to address these topics with patients. And I think what I learned at the ADAPT Clinic is that it's okay to bring these things up, and it's not like by asking those questions, you're not putting those feelings there for your patients. You maybe just be opening the door for them to talk about something that has already been at the forefront of their minds. And maybe I've had patients who are so grateful to finally have a safe place to talk about the stigma they feel because they're pregnant and they have depression and they've chosen to take antidepressants, and nobody's ever asked them to talk about that experience before. And so those three kind of big psychosocial pieces of the guilt, the shame, and the stigma, I really got comfortable addressing in my rotation at the ADAPT Clinic, and that has definitely come through in my work in other aspects as well. And I think that I'm actually out of time, so sorry that was so quick, but I will send out my slides, and if anybody has any questions, please feel free to reach out to me. It's a really wonderful rotation, and if you have the opportunity to do it, all I can say is do. It's fabulous. You will learn just so much. And it's a very niche area that I think is going to be growing a lot. So if you can get in and learn about it when you can, I really recommend that.
Thank you so much, Rebecca. Pardon me, oh dear. What an interesting rotation. I will say that I use the mental illness charts all the time in my counseling. There's a lot of cardiogenetics that is multifactorial or oligogenetic as well. And so that model has really helped me. And the whole genetic counseling is not genetic testing is kind of a guiding light for us in our clinic. So we're so grateful for the ADAPT clinic for that. So I think we'll take some questions now. I think there might have been some difficulty with being able to hear Connor at the beginning. I apologize for that. I think there were no questions that came into the audience from the audience specifically for our
just kind of broadly, patience is something that I really took away from the ADAPT clinic. They have such a wonderful model in that you get so much time with each patient. And while that is not true of the clinic I currently work in, I think what I learned from them is that, you know, you don't need to take 20 minutes to address this big psychosocial thing with a patient, but just it's not going to kill you to take a few extra minutes to address what is happening with your patient emotionally. And I think what I really just took away is that your patient's not going to hear the information that you're giving them, regardless of what specialty, if they are caught up in this big emotional, scary thing of whatever is going on for them. So that is something that I have tried to apply in my practice, and I'm still working on it in different ways, is really addressing that with patients right off the bat, because otherwise I kind of think the rest of the session kind of is a little bit moot. So I think that's kind of my biggest.
The kind of the mock calls that you had pretending to be a lab genetic counselor, I think that standardized patients or those kind of mock patients are such a good learning tool. And I'm just interested to hear how they set that up.
Yeah, so they gave me like 5 cases, and they gave me time to think through them, and they have like a template for mock calls that they also give the fellows at the lab so that they can use that when they make calls, because they want the fellows to have like the information thought of beforehand before they actually make the call. So they made me fill out those templates. And then I had a call with my supervisor to talk about them and if I was thinking about the right things or not, because sometimes just complicated one, like the one that I talked about, the baby girl getting tested for Klinefelter. I was just like, the only thing I could think was like they ordered the wrong test. There's no way they could have ordered this correctly. So that was my only thought process, and she kind of walked me through, what about this, what about that? So it was kind of giving me more information that I wasn't really thinking about. And then the day that the mock calls actually happened, what happened is I would call another lab genetic counselor, and she was pretending to be a provider. And then she would like throw me off with different things. So usually when lab genetic counselors make these calls, it's really interesting to see, mostly because like you get like you get transferred to a general like line. For example, like a nurse picks up and they might not be as comfortable with the patient, but they will be like, no, I can answer your questions. And then they hear that you're talking about like a prenatal microarray, and they're like, okay, I'll transfer you to the ordering provider. So it was kind of navigating that and trying to explain to them also, most of the times the ordering providers have no time because they're working at a NICU or they're very busy. So it's not like you can talk to them like you can talk to them in a clinical setting where you have a lot of time. So it was kind of like fast, and it's also hard because you don't have the person in front of you, so you can't tell if they're getting it, if they're understanding it, and you also don't want to be you want to be respectful. So a lot of the times when they don't offer the right test, they don't order the right test. You don't want to be like, hey, you didn't order the right test. You wouldn't be able to pick up with that. So trying to be a little more sensitive the way you portray the information and being like, oh, we would rather recommend this because it has a higher diagnostic yield, or kind of go through that. So I would make those calls and then debrief with my supervisor, seeing what she thought I did well, what I could do in the future better, things like that.
Very interesting. So we are a couple of minutes over. Now, and I hope you enjoy the recording.